Good afternoon, everyone, and welcome to the webinar. It has been a while, so we're excited to be back with you all for our webinars. Today, we have a really exciting program talking about AFib because it's not just aging sometimes. So we have Dr. Kowal here who's going to talk to us about what you really need to know about atrial fibrillation. Before we get started, I just want to introduce Mended Hearts to those who may be joining us and don't know a lot about us. Mended Hearts' mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. You can find us all over the web and social media at mendedhearts.org, mendedlittlehearts.org, myheartvisit.org, and on all of the social media platforms. We also have a heart line. If you'd like to connect with someone who has been where you are and you need some support, you can call it, and that's 1-844-HEART-87. And we have people, trained volunteers there to answer your calls. So before we begin, just a couple of notes. All attendees are in listen-only mode. So if you cannot hear, hopefully you can read the slide. Check the audio button on your personal computer to assure your sound is on. That's typically the issue. Please type your questions into the Q&A box at any time during the presentation, and the moderator will read your questions during the question and answer period. You don't have to wait to put your questions in the chat box or in the Q&A box. A recording of this presentation will be available at the Mended Hearts website following the event. And finally, the doctor was not able to answer questions specifically about you or your loved ones because he is not your treating physician. So please, when you're asking questions, make sure that they're in general terms. And so I'd like to introduce to you Dr. Kowal. He is a leading authority on current public health and cardiac topics in today's ever-changing healthcare landscape. As Vice President of Medical Affairs and Business Development, Chief Medical Officer for the Medtronic Cardiac Rhythm Management, Cardiac Ablation Solutions, and Cardiac Diagnostic Services since 2017, Dr. Kowal oversees the Innovative Technologies and Cardiac Division. So Dr. Kowal, thank you so much for being here with me today. I really appreciate it. And today's webinar is going to be a little different. We're not going to just show slides and give you facts. We're going to have a real conversation with Dr. Kowal. So thank you for joining us today.
It's a real pleasure to be on with you today.
So let's just dive right into this first topic, which is what is atrial fibrillation? And can you give us just a little bit of information about it?
Yeah, no, I'd love to, because I think there's a lot discussed about AFib, a lot out there in the media about having to detect it, find it, but very little grounding on what it is. And so, in a nutshell, atrial fibrillation is the most common arrhythmia that adults have. And by arrhythmia, that means that the heart's normal rhythm is upended and different. And so let's take a quick second and describe what normal rhythm is. And so the heart has four chambers, two upper chambers called atria, and two lower chambers called ventricles. And the ventricles are the main pumping chambers. So when you feel your pulse, which is kind of your heart rate, that is the beat that is produced by the ventricles beating and pushing blood through your blood vessels. The atria are important in two ways. They have to take blood that's drained either from the body or the lungs and fill the ventricles. And they also serve as the origin of the heart's rhythm. So it's a certain area called the sinus node of the right upper atrium that drives the normal heart rate. And when you are in sinus rhythm, a term we've probably all heard before, which is normal, your resting heart rate typically runs between 60 and 80, 60 and 90. And then when you exercise, signals from the brain and the body go to the sinus node, and the sinus node kicks up that heart rate to 110, 120, sometimes in the 150, 160 range, and then brings it back down. And all that is really exquisitely regulated. So that's normal. In atrial fibrillation, the sinus node is overridden by a chaotic rhythm of the upper chamber. So the atria, instead of beating 60 to 80 at rest are what are called fibrillating. They're almost quivering at 300 to 400 beats per minute. Well, not every one of those impulses can go to the lower chambers. And what happens is the pattern of beating from the lower chambers, which causes your pulse, as we said, is irregular and erratic. And that's why with atrial fibrillation, you can have an irregular pulse or a fast pulse, depending on how those signals come through. Now, that has a bunch of consequences that come with it. Some of them are related to symptoms. And so people can have a range of symptoms, from feeling that irregular heartbeat manifest in their symptoms in their chest, or fatigue, or some other vague things that we can talk about more. But then it also brings in other complications, and that is it's a predisposing risk factor for stroke, for heart failure, even premature death. So understanding who is in atrial fibrillation and trying to get the right therapy to people is really key.
Right. So it sounds like, I mean, with dizziness, short of breath, tired, that sounds like sometimes it could be confused with aging.
Yeah, absolutely. So it can be really hard to kind of sort these symptoms out. And so the complicating factors are across a variety of people. The symptoms can be very different, and I'll describe that in a second. But likewise, even in the same person, the symptoms can be different. So the symptoms can range all the way from, when you're in atrial fibrillation, you just can't do anything because you're so short of breath, so debilitated, your heart rate is so fast and irregular that you kind of just have to sit down and wait till it's either over, or that you can take some medications to slow your heart rate down. On the other end of the spectrum, it can feel like nothing at all, right? So just maybe something minor, like I'm a little short of breath now when I climb the stairs, and 2 weeks ago I wasn't, all the way to no symptoms at all. It is interesting. One of the symptoms that people describe quite a bit is that they feel like there's a tennis ball in a dryer in their chest, right? That sense of this irregular pounding around at different intensity, and that's going on in the chest. And so from a physician standpoint, when you're talking to a patient, it's really hard to know where on the spectrum someone is. And you can see that if they have no symptoms at all, unless you do a test for atrial fibrillation, you can't find it. Now, the other interesting thing is that people can present, the same person can have different symptoms with the same problem, atrial fibrillation. And so we've had people who, very characteristic, that they will present to a doctor feeling either fine, or maybe they've lost a step or two and they came in to get checked out. They get an EKG and a physician finds atrial fibrillation. Hasn't really bothered them that much, but then normal rhythm is restored. And even then, sometimes people say, well, I'm not sure that did anything, doc. And then they go back into atrial fibrillation and suddenly they feel it. And hard to explain why that is, other than we know there's that variation. And likewise, there are people who have atrial fibrillation and can feel it, who other times they feel exactly the same way, like they're in atrial fibrillation, but if you get an EKG at that time, they're in normal rhythm. And so you can have atrial fibrillation and not know it. You can have atrial fibrillation and know it, and you can be in normal rhythm and feel like you're in atrial fibrillation. All that is well known and normal. So anyone who's listening who has those variations, that don't feel like you're an outlier. That's part of what makes this difficult.
Sounds really difficult and kind of confusing. And I would imagine that if you're a patient and you're experiencing these types of symptoms, but you go to the doctor and they do an EKG and they say nothing's wrong, then what? What should they do?
So you bring up a great point. The hallmark of identifying atrial fibrillation is a couple things. One the main one is getting an electrocardiogram, which measures the exact heart rhythm electrically. And we can then see, is that atrial activity normal or abnormal? And then how fast or irregular is the lower chamber? But you're right. Some people are, when they go into atrial fibrillation, are in it all the time. and can have varying symptoms, and that's called persistent atrial fibrillation. And others go in and out on their own, what we call paroxysmal atrial fibrillation. So you could have these symptoms, they could represent atrial fibrillation, but then it stops on its own when you get to the doctor, and then an EKG is normal and you're left not knowing what to do. The good news is the technology to try to discover atrial fibrillation when you have symptoms like that is come a long way. And so there are a range of technologies, from something we make where there's a small monitor that can be inserted under the skin and can monitor almost continuously for years, that you can mark with symptoms, to kind of monitors that you can wear either for a day or up to 14 days and even 30 days to kind of watch out, again, where someone can press a triggering point when they have symptoms, and then we could correlate the symptoms to the heart rhythm at that time, or just monitor. And then now we've got kind of, the watches and different devices we wear that can tell you that your heart rate is irregular or give you a quick look EKG. And those are becoming, ever more sophisticated now. And then even things like blood pressure monitors can tell you, hey, your blood pressure is, whatever, 130/80, but it can distinguish sometimes when it's irregular. And if you see that it's irregular, that may be and you see that multiple times, that may be a sign that you have atrial fibrillation, or at least some kind of rhythm abnormality that's worth getting checked out.
Great. So I know it's important to know about atrial fibrillation, but why is it important to detect it early?
Yeah, so that's a great question. And one of the key factors is related to what can happen when you're in atrial fibrillation. And if left unchecked over time, one, it's progressive, meaning for a lot of people, if they start with short episodes, they will progress to longer and longer episodes till you're in it all the time. Now, that can be, for some people, a very rapid course, and for others, years before that happens, but it's hard to predict. But the second thing is that with atrial fibrillation comes the risk of stroke and heart failure, and other ailments, even an increased risk of death. And I'll get to what we've learned in terms of treating earlier, because that's evolved over time. But I think the key factors to understand is that you have to get with your physician, develop a relationship, and start kind of parsing down what are the pieces I have to think about. And I think there are really three pieces that you have to kind of manage. First is the stroke risk. So when you have atrial fibrillation, the stroke risk you have is elevated, but that degree of risk is a function of some of the other problems you might have. If you have high blood pressure, if you've had a prior stroke, if you have other vascular disease like coronary artery disease, those, and it's a function of age as well. So you have to piece together that, and we're also learning it's probably a function of how long you're in atrial fibrillation as well. So it's complicated. And so the good news is that even though there's an increased risk of stroke, there's therapy for that, and it's blood thinners. And so there's a set of medications called anticoagulants that lower the stroke risk that you have with atrial fibrillation dramatically. So those who are among a higher risk group have options. And then there are other types of devices that could be used too if they can't take those medications. So step number one is to work with your physician to see, do I have the risk level that suggests I should be on one of these drugs? And do I, am I free of the risk factors that make me at higher risk of bleeding if I have one of these drugs? So that's one compartment. The second compartment is, what do I want to do about the rhythm itself? And so this has evolved, right? So two options can occur. I can either, you can either say I'm going in and out of atrial fibrillation, or I'm in atrial fibrillation, and I'll just manage the symptoms and the heart rate and leave my heart in that rhythm, or I can work to try to maintain normal rhythm. Now, a lot of that depends on the symptoms you have, although there's increasing evidence that trying to treat and restore or maintain normal rhythm earlier in the course of the process of atrial fibrillation may be better, at least in some patients, than letting them stay in atrial fibrillation. Prior trials suggested that those were equivalent strategies. Newer trials suggest the earlier you treat to maintain normal rhythm, the better. And again, this is one where there's no absolute, right? You have to kind of work with your physician to understand your circumstances and what's the best option there. And we can talk more about kind of what are those options to get in a normal rhythm, because that's particularly where Medtronic and our company is among several others that are working extensively there. But that's also not enough, right? The third piece is all the other factors that come with atrial fibrillation or are impacted by that impact atrial fibrillation. And so many people who have atrial fibrillation also have high blood pressure. Some are obese, some are pretty sedentary, and some have sleep apnea and other lung issues that can drive the drive towards atrial fibrillation. They feed on themselves. So you can't just manage the atrial fibrillation in an exclusion. Got to look at the person, your patient as a whole, and look at things like, I've got to get my blood pressure under better control. I've got to get on a regular exercise regimen, diet and lose weight if you need to. All these other things that come together. And so when you talk to your physician, it's not just about the AFib. Ask about these other things as well, because some of those are almost as, or can be even more important sometimes to manage.
Okay. So, you hear that AFib can be a lifelong disease or a lifelong burden. When the standard treatment fails, which it does, I know at a high rate, what other options are there for patients?
Yeah, so let's get into kind of how you treat. We talked a little bit about kind of stroke prevention. As you start thinking about kind of the symptoms I laid out and the arrhythmia, and the fact that the rhythm abnormality is causing symptoms and problems, we want to keep those symptoms under check. And like I said, there's now new evidence that if you treat the rhythm itself earlier, you may be able to prevent things like the earlier chance of dying or the heart failure, things like that. And so, what are the things you can do? Well, it used to be that the first line of approach was a set of drugs called antiarrhythmic drugs. And these are drugs that are designed to kind of stabilize the upper chamber back into normal rhythm, and help maintain it and either prevent AFib from recurring, or if it occurs, to keep those episodes short and stop them without having to go to what's called a cardioversion, where we shock the heart back to normal rhythm. As you pointed out, the problem with those drugs is that even though they can work, at best, they fail about 50% of the time within a year. And so if you're in AFib all the time, and you have one recurrence a year for a few minutes, that's probably a success on a drug like that. However, if you're having to keep coming back in because you keep having recurrences and symptoms, that's not success. And likewise, these drugs can also have side effects. So some of those side effects can be life-threatening. So again, those drugs have to be matched to a patient. Well, there's also a procedure called catheter ablation. And what's targeted there is certain hotspots in the left upper chamber, the left atrium, that are triggers of atrial fibrillation. And these are often at the area where blood drains back from the lungs back into the heart, a structure that we call the pulmonary veins. And if we freeze or burn as a certain pattern at that site and try to eradicate these areas that trigger atrial fibrillation, we can have a reasonably good success at getting rid of it. Now, I'd say cure is probably not the right word here, because it can recur. And so on average, people who get this procedure, depending on their kind of other complexities, can have a successful procedure so that at 1 year, between 60 and 85% of them are not having any recurrences of atrial fibrillation. But what we also know is that a lot of these people, even if they have a short recurrence, the amount of atrial fibrillation, the burden they have goes down a lot. And so if you're having symptoms and it's happening, 5-10% of the time, and you can drop that down to a fraction of the time, that's a win as well. And so the choice of whether to go to a medicine or an ablation procedure has changed a bit in terms of, it used to be you always started with a medicine first and then would go to an ablation procedure if that failed. With our technology, a catheter that freezes instead of burns, we now have evidence that you can, for selected patients, they can do better going straight to the ablation procedure. But again, that's not necessarily for everybody. And so I think it's really critical here to have this kind of rich discussion with a physician about all these aspects of care and figure out what's going to be the best approach for you, and understand this is not going to be a one and done. This is a lifelong process of keeping that rhythm the way you want it, keeping all these other comorbid things like hypertension in check and managed. And again, this stroke risk issue is going to be a lifelong management issue where you might start with something now and it may evolve over time. But these are the three things that you're always going to have to work with your physician on.
Great. So I have a question, because I know we talk to a lot of patients, and there's a discussion a lot of times of, does AFib cause the other heart issues, or like heart failure or heart attack, or is the AFib a result of these other heart diseases? So can you talk a little on that? Is it both? Is it none?
It's a fantastic question, and the answer is yes, right? So it's one of those where, so heart failure is a great example. Those who have heart failure have a much higher chance of developing atrial fibrillation if they've never had it before than those in the absence of heart failure. And likewise, those who have normal heart function who develop atrial fibrillation have a much higher chance of developing heart failure, particularly if they stay in atrial fibrillation for a long time and if that heart rate is not kept in check. And so it's this kind of feedback loop, feed forward loop, where one makes the other worse and the other keeps going. Now, in terms of things like stroke, there's a clear relationship between atrial fibrillation and stroke, but it's not as simple as I've had an episode of atrial fibrillation, so I'm at risk for stroke in the next X number of day window. It's more complicated than that, and we're trying to understand, is the atrial fibrillation changing the atrium to make it more susceptible to forming blood clots that lead to stroke? Is it the atrium that's changed that now makes stroke and AFib more likely, or is it some aspect of both? In the end, we'll keep learning that, but it somewhat doesn't matter from the standpoint of, you still need to manage those issues and make sure your stroke risk is adequately, one, recognized, and then two, treated if it's severe enough.
Great answer. So where can people here go to learn more about treatment options for AFib? And then I will share about learning about how to empower yourselves as a patient.
So I think this is a great question. And so the subspecialty of physicians who probably knows the most about atrial fibrillation are cardiac electrophysiologists. That's what I did for many years in practice. So I have a bias towards our subspecialty, clearly. But really, it's not going to start with an electrophysiologist usually. Now, some people, I will say, are learning about their atrial fibrillation from watches and other things. So there is a more direct path sometimes, but usually it's a primary care physician or sometimes a general cardiologist who finds this or has started the exploration in the setting of certain symptoms someone presents with. And then that triggers the cascade. I think the key, though, is you want to get to someone who really understands all the options available as soon as possible. Because as I said, there's more and more evidence that the faster you get into a treatment plan across all three of those areas that I mentioned, the better you're going to do. And so you don't want to sit around kind of bouncing doctor to doctor for several years before you get to someone who really understands it. Sometimes it's as simple as going on the web and looking at what, which places have atrial fibrillation centers, and look for physicians who treat this regularly, and talking, having a candid and frank conversation with your primary care physician about, who they're using for this, because not everybody spends a lot of their time treating it.
Yeah, and it's a great time to bring up the Mended Hearts has it 7 steps to an empowered patient. And we talk exactly about that, educating yourself on all of the options, having very open and honest conversations with your physician, but also knowing that if there are options and treatment options that the physician is closed-minded to, you need to be able to open that discussion and ask the questions, and ask the important questions about why is this not something that we can consider. I think
that's really key. And, I've had conversations with my own patients about second opinions. Don't be afraid to get a second opinion. I think to some extent, if there's a physician who gets insulted because you want a second opinion, you may need to see someone else, right? It's as simple as that. Because this is complicated. It's a field that continues to evolve, and we go to our scientific meetings, and you can find a panel of 5 physicians who may have 5 different views on the same thing. It's not because one is right and one is wrong. It's how they interpret it, and the fact that each patient is different and has to be individualized. So I think it's very reasonable to get a couple of opinions about what the various options for you might be, and then weigh which one works for you. One, that works with what you want to accomplish in feeling better, and who you have the most rapport with, because you're going to be working with that physician for a while. So you should be able to have a relationship where there can be interchange and questions asked and answered.
Yeah. So what is the impact of AFib on diverse and oftentimes underserved populations of America?
Yeah, no, this is a great question, and we're learning this. So a couple of things we do know is that, so for example, African Americans tend to have less atrial fibrillation, but they have more of the risk factors that can lead to atrial fibrillation and cause problems if you have atrial fibrillation, namely hypertension. So if an African American has atrial fibrillation, their stroke risk may be a bit higher than non-African Americans. Likewise, when you look at treatment options, there's clearly unconscious bias in how people are treated. So women and different ethnic groups tend to be offered therapy like ablation less than others. Not clear why that is. There's research going on to understand that, but a lot of work being done to make sure that one, we understand what are the best options, and are there any differences in how different groups should be cared for, how they respond to, for example, ablation or medications. And secondly, how do you tear down those barriers of care? Some of it is education of physicians. Some of it is education of patients who may not know to ask these questions.
Yeah, and you brought up a great point about women, and I think that there is evidence that shows that women are less likely to be given treatment options due to the fact that it may be considered anxiety or something of that nature when they present with heart palpitations or an irregular heartbeat that they report to their doctor.
Yeah, no, that's very clear. And also, for example, if you look at things like coronary artery disease and chest pain, and the risk factors for heart attack, women often present with slightly different symptoms than men. And for years, we were always taught how men present, and not necessarily women. And so we're learning those differences. And as physicians become more aware, the antenna is up and broader. But you're correct as well. A lot of times, especially heart rhythm type disorders, are viewed in women more as anxiety caused by anxiety than potentially in men. And because there's a lot of mimicking, right? People who are anxious, their hearts race. And likewise, your heart racing makes you anxious. And so there's this catch-22 there, but the key is to kind of remove the gender bias and make sure people are looked at and go through the same kind of diagnostic regimen so that we can kind of find and treat what needs to be managed.
Great. Well, I have one more question and then we will go to the Q&A because it's filling up.
Okay.
The last question I have is, so what can healthcare providers and organizations like Mended Hearts do to reach the underserved population with education and support?
Yeah, no, I think it's continuing to do what you're doing. Get these kind of information out there in a form that people can get to no matter who they are. The web is a great equalizer here. There's also the opportunity to do kind of local education as well. Community centers, churches. We in medicine have only recently kind of opened our eyes to the fact that we can't expect everyone to come to us. We have to be able to go to where people are, and different people find their information at different places. And I think the more we can kind of go to other people, to the world of the patient rather than forcing them into our world to get information, the better we'll do at getting kind of a broader base of people who get the therapy they need.
Great. Well, thank you for that. Mandy, I think that we can turn it over to question and answers. If you have questions to moderate out, that'd be great.
Yes, we have a lot of questions. So Vicky asks, she says she has atrial flutter. Her symptoms during episodes are similar to what you described for AFib. Can you summarize where these two arrhythmias are functionally different?
So, it's a great question. So as I mentioned, atrial fibrillation is when the upper chambers are complete ability to see any kind of organized path leads to a very regular coming from the lower chamber, the ventricles. The atrial flutter is also a very rapid heart rhythm, but it is more regular and organized. And as such, tends to be coming from one specific location in the heart. And as a result, is often much more amenable to a catheter ablation procedure because you only have to narrow down that area to a small region. And so they can mimic each other quite a bit. But again, the EKG, the electrocardiogram, is often the most important thing at distinguishing what's what. Now, the other complicating factor is some people have both. And so they'll be in flutter sometimes and fibrillation in other times. And it's important to understand that because sometimes you can have your atrial flutter successfully treated and then come back with atrial fibrillation later. And so just if you get your flutter treated, just know that you may not be completely done with the problem.
Thanks. This question's specific, but I think we can make it broader. He or she asks, after 5 months after ablation, can you stop Eliquis? But I think probably it's more of a medication adherence and the importance of that.
That's a great question. And again, goes back to being individualized. So everybody who undergoes an ablation procedure needs to be on some anticoagulation drug, and Eliquis is one of those. And why is that? Well, first off, when you do these ablations, you're making changes to the tissue in this left atrium. Well, the left atrium has direct connection to the ventricle that's pumping blood to the body, to the brain, and the kidneys and the legs. So if there's a small blood clot that forms on the tissue, that could break off and cause a small stroke or some kidney damage. And so everybody stays on a blood thinner for a short period of time after ablation, no matter what, to prevent that risk. And it's very manageable. It brings the risk low. The field has kind of sorted that out. That said, as I mentioned, some people have a higher risk of stroke that's measured from kind of a score factor called the CHADS-VAS score. And if you are above a certain level and you don't have risks of bleeding on these drugs, it's recommended that you continue on those medications in order to prevent the risk of stroke long-term. no matter what the result of the ablation procedure are. So that's something that it's worth talking to your physician about. Make sure you're on the same page. If you go down the route of ablation, what does that mean in terms of the anticoagulation long-term? Because it's better to know that up front and what to expect than kind of be disappointed or unclear at the back end of what you're trying to accomplish with the ablation procedure.
I don't know if you can answer this one from Ed. He's got two. What is more likely to trigger AFib, excessive coffee or excessive alcohol? And then what quantities of each would be likely to trigger an AFib?
Yeah. Great question. So the trigger factors for atrial fibrillation are really hard to quantitate because they're very different. And so just like symptoms from patient to patient are different, they're very different. These triggers are different from patient to patient. And so, so for example, if you look now, coffee has not been shown to be a big trigger in large populations of people, because for some it does, and for others it doesn't. So the signal gets drowned out. For some people, it's caffeine is a dramatic trigger for arrhythmia. And like I said, in a lot of others, it's not at all. Alcohol can be for some. I remember a patient very distinctly, if they had a couple glasses of wine or a few beers, they would go straight into atrial fibrillation an hour or two later. Others makes no difference at all whether they consume alcohol in triggering. So it really, the question to some extent is unanswerable for a group as a whole, but it is answerable on an individual basis. And that's why I used to tell people, keep a sense of when this is occurring and what your triggers are, so you can try to kind of modify or avoid to you. But the hard part here is there's no hard and fast rules. Some people exercise triggers atrial fibrillation. Some people it's the exact opposite, where they exercise their way out of it. I know it's not a very reassuring answer or one that's kind of satisfying, but again, that's the complexity of this.
What's the typical origin of the irregular signals? I've heard it can originate in the pulmonary vein, but I've also heard they originate in the atria itself.
Yeah, and so that's a great question. And, I think one thing to kind of understand is that there's no kind of hard and fast demarcation between what is this pulmonary vein draining blood into the atrium and the atrium itself. These tissues come together, and the atrium is formed from tissues that have varied kind of origins embryologically. And so without getting too geeked out in the conversation, there's no easy way to say, wow, that's the atrium and that's not. There's some exceptions to that. And so most people have triggers that come from that pulmonary vein area, and a minority of triggers that come from other places as well. But to some extent, the atrium has to have some degree of abnormality to accept those triggers and keep it going. So it's this complex interplay of the triggering and the ability to maintain the rhythm in the atrium. And then the longer you have it, the more the atrium gets diseased and disrupted, and the less you need those triggers in the pulmonary veins. So again, as best we understand, for most people, for the average person, the pulmonary vein is the dominant source, and the earlier you can get to it, the less these atrial triggers are relevant. But again, everyone's different. I remember I treated a person who was 23 who had a non-pulmonary vein trigger as their only spot. And she's now, it's 15 years later, so she's in her late 30s and just contacted me that she's never had it again. And she's pretty unique. She's not typical, but again, this is the variation that you can see from person to person.
Joanne asks, is PVC the same as AFib?
Yeah, so PVC stands for premature ventricular contraction. And so those are extra beats that emerge from the lower chamber, the ventricles. And so that's totally different. Now, what you can have is what are called PACs, or premature atrial contraction. And those are single beats that are kind of mistimed in the upper chamber. Both PACs and PACs can seem like atrial fibrillation if you have enough of them, because they simulate an irregular rhythm because they're not occurring with that normal sinus pattern. But it's not quite the same. They don't carry the same kind of risk. For sure, the PVCs don't if they're infrequent. The PACs can be a marker that you're at a higher risk for developing atrial fibrillation, but it kind of depends on how much of it you're having.
A couple of people have asked, is there anything that they can do to stop the symptoms once they're in AFib?
Yeah, I think the key is related to oftentimes getting the heart rate slowed down when you're in atrial fibrillation, because a lot of the symptoms are related to the rapid rate as opposed to just the irregular rate. And sometimes it's the irregular rate too, but so if sometimes you'll talk to your physician, and if you have a medication that slows the heart rate down, like a beta blocker drug or a calcium channel blocker drug, sometimes your physician may tell you, in the setting of an episode, you may want to take an extra dose, but don't do that without talking to them first and having a plan of action, because the last thing you want to do is overly slow your heart rate down, and it can be a balance. But people can often get really good at adjusting their medications to kind of cut down those episodes when they're very symptomatic.
This is a personal question, maybe a little. Karen asks, she has 2 leaky valves in her heart, and does that affect her going into AFib?
Yeah, so that's a great question. So like I said, we talked about before, atrial fibrillation can cause things like heart failure, but other things can increase the risk of atrial fibrillation. And one of them is a leaky heart valve, particularly the mitral valve. Often, and if not a very common problem in the US, but if the mitral valve is what we call stenosed or too narrow, that's a big trigger for atrial fibrillation. So it's really important to kind of understand the relationship between the severity of, let's say, the leaky valve and the atrial fibrillation, because you want to know which one to treat first, right? So if your leaking valve is mild, that's probably not triggering your atrial fibrillation, and your doctor might suggest treating the atrial fibrillation first and seeing how the heart valve function does. If it's severe, though, if the valve leaking is severe, then you could try all you want to treat that atrial fibrillation, keep that rhythm normal. It's probably not going to work unless you do something about the valve. So again, it's complicated, and that's where second opinions and making sure you're talking to a variety of experts, not only on the valve and the rhythm. And this is where centers where the various types of cardiologists talk to each other and interact with each other in kind of a more holistic manner are really key. Because you don't want to get into an argument where you go to one doctor and he says, you have to do this. You go to the partner and no, you have to do that. You want them talking to each other to come up with the best plan with you.
Fredonia asks, can you give an example of some of the drugs used to stabilize the rhythm in AFib?
Yeah, there are a variety of them. So, and they fall into a couple classes. And so one class includes drugs like propofenone and flecainide. Those affect one type of protein, or what's called an ion channel in the heart, and try to stabilize the rhythm. There's another class that affect potassium channels. Sotalol, or the brand name of that is beta-pace. Another one is amiodarone. And each of them works a little differently. And depending on what other conditions someone may have, a physician may make one choice or another related to what that best option may be, if you go the route of those medications. And then I would add that in addition to the blood thinners, there's also medications that I mentioned just to help keep the heart rate under control. And those are kind of beta blocker drugs or calcium channel blocker drugs that in the setting of atrial fibrillation or even flutter kind of slow the impulses from getting to the lower chamber of the ventricle. So you keep that heart rate from racing too fast.
How does having a mitral valve replacement and then having AFib after can you talk about the relationship between those?
Yeah, so again, mitral valve disease is a pretty strong trigger for atrial fibrillation. And then likewise, anytime you have surgery to fix either a heart valve or even coronary artery surgery, probably related to all the inflammation related of the surgery, you're at higher risk for developing atrial fibrillation for at least a period of a month or two afterwards. And that's particularly true after mitral valve surgery. So, that's something to keep an eye on if you've had surgery and then, a few weeks later, you're feeling like, wow, I was getting better and now I kind of fell back down again, or I feel these palpitations after your surgery. It could be some atrial fibrillation. It's worth getting checked out.
We've got a couple of questions about the Watchman and about innovations with pacemakers and other devices. Can you just touch on that?
Yeah, no, I think there's a lot of new stuff emerging. As I mentioned, for example, in the ablation realm, we have some evidence now with one tool called the cryoballoon that it's safe and effective to use earlier in the course. For those, the Watchman is a device that sits in a portion of the heart called the left atrial appendage to try to prevent blood clots from forming there, and can serve as a replacement or an alternative to blood thinners in patients who can't tolerate it. So that's one device. There's another device that was just FDA approved called the Amulet device. These are all under the class of left atrial appendage occlusion devices. There are certain modes to where pacemakers can help. And so, for example, we have an algorithm in our pacemakers that can't convert atrial fibrillation. It's too complicated. But if someone switches from atrial fibrillation to flutter, it can use pacing maneuvers to try to terminate that flutter back into sinus rhythm. And we've seen some efficacy there. So again, a lot of different things being worked on or in the marketplace. But again, what I caution people against is kind of getting fixed on one thing, right? I think what you don't want to do is say, I have to have this treatment and then find the person who's going to kind of deliver on that. What you really want is that person who's going to help you form a plan that says, okay, stroke prevention, do I need it? Am I going to use a drug or am I going to use a device? Rhythm control, is that the right thing? If that's the case, is it going first to an ablation or to a drug? If so, what are my options to do? And then comorbidity management, whether it's losing weight, controlling blood pressure or sleep apnea. How am I going to do it? Maybe this doctor doesn't do all that, but they can recommend some specialists or allied professionals who can help with that. And so the key is getting a plan for each of those and seeing your plan through, as opposed to just saying, I'm going to pick this one thing and find someone who's going to do that thing for me or to me.
Two questions that fall into the same category. What is a loop recorder and why would you put one in? And can I trust Apple Watch when they're checking for AFib?
Oh, that's a great question. So a loop recorder is a device that, is about, I wish I had a model of it in front of me, but I don't have one handy. But they're about an inch long and maybe a quarter of an inch wide, and they slide under the skin, kind of in the chest area here, over the heart. And it's basically what's called a single lead EKG. And so these devices can be programmed to watch for a variety of rhythm abnormalities, including very fast rhythms coming from the lower chamber, fast rhythms coming from the upper chamber, such as atrial fibrillation, pauses, and other stuff. And so a couple things. They can, if you don't know what's going on and you're having a lot of symptoms and shorter term monitors like an EKG or a 7 or 14-day monitor can't find it, the loop recorders can be very effective at finding the cause of these. And then likewise, once you know you have it, as you're looking at how to follow and manage, there are people who find that there's some benefit to having this kind of continuous tracking of when I'm in AFib, when I'm not, and particularly after an ablation, you can use them to determine whether the burden of atrial fibrillation, the total amount has gone down. And so that's what loop recorders can do distinctly from other tools. I think it's a question, again, with you and your physician, is that something you need or not? Is that something that's going to benefit your care for the situation you're in? The Apple Watch one is an interesting one. So first off, what we have information about its ability when it says you have atrial fibrillation, it's pretty good at being right about that. What we don't know is its ability to detect atrial fibrillation of whatever duration you're having, if you're having it. So in other words, we don't know what it's missing. So we know that if it tells you you're in atrial fibrillation, it's probably pretty good. We don't know yet how much of it it's missing, particularly if you have episodes that are, less than 24 hours. And so, again, I think when you look at the FDA labeling for Apple Watch, it is not for diagnosing atrial fibrillation. So I think you have to put it into the context of how Apple describes its use based on the FDA of what you can do with it. And so it's going to serve very different needs than, for example, a loop recorder or a 14-day patch monitor. And so understanding these capabilities and where they can fit in to your care is key. But it's not as simple as I can use this to replace that. These things are complementary tools.
Can you describe the difference between ablation and cardioversion? And for how many years has ablation been available?
Yeah, no, great question. So cardioversion is giving a very high voltage shock to the heart to basically take the rhythm that it's in, kind of cancel it for a split second, and let the sinus rhythm kick back in. Think of it as jump starting the heart. And cardioversion can be used, or defibrillation is the other term, is used to treat life-threatening cardiac arrest. So when you see on TV, the ambulance comes, shocks the person out of a life-threatening rhythm called ventricular fibrillation, it's the same tool, but it's used to stop the atrial fibrillation and reset the heart. That's a kind of an instantaneous event. But the problem is you can go back into atrial fibrillation if you're not doing something to try to prevent it. But it's very effective at stopping the atrial fibrillation when it's occurring, if other things aren't doing it, like if you don't get out of it on your own or the medications you're on. And so that can be very effective. Ablation is a little different. Ablation isn't designed to kind of terminate the atrial fibrillation if you're in it, although there are some cases where that occurs. Really what you're trying to do with ablation is modify the tissue, something that the cardioversion is not doing long-term. But with ablation, to modify the atrial tissue long-term to reduce the likelihood that the atrial fibrillation is coming back. So one is an instantaneous reversion back to normal rhythm. That's cardioversion. The ablation is really, let's make a modification to try to lower the chance that that's going to come back.
That makes sense. Thanks. Clarence asks about women, and do you think that one of the reasons AFib is more prominent in women could be because of hormones? Is that the different hormone differences?
Yeah, I'm sure that those differences play into it, but understand that some of these differences are present postmenopausal as well. So I think it's more complicated than that. And so I think it would be a little bit of an easy answer to say, yeah, that's it, and move on. I think it's probably a little bit more complex. And not only kind of scientifically differences, but again, this social overlay of, people for a long time view women's problems related to it as more likely to be anxiety than they would do for a man. And we've got to get over that.
Thanks.
Or change it, not get over it, change it. Get past.
Yeah. Could you speak to, this is kind of a personal question again, a person with WolffParkinsonWhite, any more likely to have a reoccurrence after an ablation?
Yeah, so WolffParkinsonWhite is kind of a very unique condition where someone is born with an extra piece of kind of electrically conductive tissue that kind of creates a little bit of a short circuit between the upper and lower chambers. That can set off kind of a very regular short circuit called supraventricular tachycardia, and is readily treated with ablation and sometimes medications. And the reason for that is that short circuit tissue is very focused and often not too hard to find, locate, and eradicate. That said, those with certain subsets of patients with WolffParkinsonWhite are more prone to atrial fibrillation as well. And it's the literature is a little bit unclear as to kind of if you typically was taught that if you fix the WolffParkinsonWhite, your AFib risk goes down. I think it depends on how old you are when you get that fixed. I think the key is if you've had WolffParkinsonWhite and you've had a lot of of these abnormal heart rhythms related to it, and particularly if you've had an ablation procedure, as you're getting older, you've got to kind of be aware that sometimes you may develop a new type of symptom, whereas with WolffParkinsonWhite, it was very fast and regular palpitations. If you start feeling irregular ones or just something different, you may have kind of flipped over into kind of a pattern of atrial fibrillation rather than that supraventricular tachycardia. But these are, people, it's less common. About 1 in 1,000 people are born with WolffParkinsonWhite.
Okay.
So Mandy, I think we have time for one more question.
Okay. There's a couple that are a little bit specific, but I think I'd like to just finish it with where should people go if they want more information? Because on this, where online are some good resources?
Yeah, there's some, so a lot of medical centers have good websites, sites like this one. Mended Hearts are good sources and of where you can get more information, where to go. There's some patient advocacy sites. One is stopafib.org. So there are resources out there, and I think the key is to start with your primary care physician and who they would recommend if you need to see someone. But again, I would go to a couple websites, and what you'll see is that a lot of you want to see some overlap in the information to make sure you're not kind of off in the weeds on one side and not another, and make sure that they're kind of correlating with each other. But again, I think there's a good balance to be had between kind of the medical websites that give you kind of a lot of the kind of information I'm giving, but don't undervalue the patient sites, because you can feel pretty alone when you have these problems. And to hear that, wow, this person has the same kind of symptoms and someone else has different is kind of reassuring that you're not an outlier, right? That this variation and how this could present is part and parcel of the whole package. And so don't get caught up if someone's AFib presents differently than yours, but it is good to see, how others have gone about navigating, getting to the right spot and getting the right care.
Great, thank you. And I would just like to say, you can also visit medtronic.com at treat AFib. The /treat AFib, lots of great information there. Mended Hearts,
our own site.
That's okay. I'm here for you. I think it's fabulous. And we share that a lot with our companies. It's really important because it gives you lots of great information. And if you take what you said, take that information, pair it with the medical information you're getting on the patient side, you get all three of those sides, and then make sure you're not off in the weeds, with some conspiracy theory, but really great information that you can utilize with your physician and have a conversation.
Now, again, the key is don't wait. If you think something is not right, get it checked out. Because again, the earlier we can jump on this, the better overall things can be.
Great. Well, Dr. Kowal, thank you for spending the hour with us. We really appreciate it. It always goes by too fast. For everyone watching, thank you for joining us. We will have the recording up on the website within the next couple of days. So thank you, Dr. Kowal, for spending your time with us.
A pleasure.
Bye-bye. Have a great day.